Welcome to Module 2. In this module, we will cover the benefits of quality improvement programs. The information in this presentation is largely based on the guidelines for trauma quality improvement programs published by the World Health Organization. On your screen is the internet address where this document may be found. The core learning objectives of this module are to provide a basic understanding of the following: review of the benefits of trauma QI, experience of trauma QI in low and middle income countries, experience of QI in other fields in low and middle income countries, and the status of trauma quality improvement globally. In order to ascertain the evidence base that supports the recommendations contained in this course, a review of the published literature on the effectiveness of trauma QI programs was conducted. A brief summary of the findings of the review are presented here. Details of the review are contained in the Guidelines for Trauma QI Programs. The search strategy sought articles that reported on QI programs or measures that were primarily oriented toward trauma patients. In order for an article to be included, the program or measure had to have been used to identify correctable deficiencies in trauma patient care, to generate interventions to improve the weaknesses detected, and to evaluate the implemented solution through measurable outcomes. Articles were not included in the review if they only described QA methodology without evaluating the efficacy of an intervention, if they did not include utilization of QI measures to identify the problem requiring intervention, or if they relied only on subjective evidence such as expert opinion. A total of 36 articles were identified to fit the search criteria. Most, or 30, of the articles found discussed QI for trauma patients in the hospital context, while 4 addressed system-wide QI programs and 2 involved the pre-hospital setting. 13 studies evaluated changes in mortality associated with QI, while other patient outcomes such as infections, pressure ulcers, and other similar complications were the main outcomes assessed in 12 studies. Process of care indicators were the main outcome assessed in 11 of the studies. Of the 36 articles reviewed, the vast majority, or 34, found improvements in mortality. Other patient outcomes were process of care, while only 2 studies detected no difference after a QI program or method was implemented. No article reported a worsening of any outcome from a QI program. Thus, this literature shows that trauma quality improvement programs consistently improve the process of care, decrease mortality, and improve other patient outcomes. Further efforts to promote quality improvement globally are warranted. There is a growing body of work on the implementation of QI methods for trauma care in low and middle income countries in many areas of the world. The methods are reported to be useful in identifying problems that can be assessed through corrective action. However, so far, only a few of these countries have documented improvements in outcome through such corrective action. The CON-CAN report is one of the few such articles that reports on the effect of a QI program on mortality rates. The CON-CAN hospital serves a wide rural area in northern Thailand. In order to confront the growing problems of trauma, a trauma registry was set up in the mid-1990s. The trauma registry indicated a high rate of potentially preventable deaths. A trauma audit committee reviewed the process of care on expired cases and found a variety of problems, both in the action of individual practitioners and in the system. These included difficulties in the referral system, the emergency department, the operating rooms, and the intensive care unit. One of the shortcomings found was the inadequate resuscitation of patients in shock, both during referral and in the emergency department. Likewise, a high rate of delayed operations for head injuries was also noted. Throughout all of this, there were deficiencies identified in record keeping and communication among hospital personnel. Corrective action was targeted at the identified problems. This corrective action included improving communication by radio within the hospital, stationing of fully trained surgeons in the emergency department during peak periods, improving orientation on trauma care for new junior doctors joining the surgery team, and improving the reporting on trauma care through hospital meetings. The Trauma Registry was able to demonstrate that these improvements increased compliance with medical audit filters. These changes in process were also associated with an improvement in mortality. Overall mortality among admitted trauma cases decreased from 6.1% to 4.4%. These improvements were brought about primarily through improved organization and planning without high cost investment in new equipment or infrastructure. The Trauma Audit Committee found problems at the following levels. At the systemic level, difficulties in the referral system, the emergency department, the operating room, the intensive care unit, such as inadequate resuscitation and delayed operations for head injuries. At the individual provider level, deficiencies in record keeping and communications were identified. As far as corrective actions taken, such as stationing a full-time trained surgeon in the emergency department, improving orientation on trauma care for new junior doctors, improving communication by radios, and improving recording on trauma care throughout the hospital meetings. This novel approach destigmatized the individual as a target to blame for unfavorable outcomes and emphasized a broader understanding in that QI requires awareness that the system is also contributing to the error. Peer-reviewed preventable death panels have become increasingly used in low and middle-income countries. A preventative death panel reviews deaths at either an individual hospital or system, looking for deaths that are considered by consensus to have been preventable. Preventable death panel reviews will be discussed at length later in the agenda. In Pakistan, a peer review process was employed to identify preventable deaths and potentially preventable deaths in trauma patients admitted over a 2-year period. The process reevaluated possible areas for improvement in system-related factors such as appropriate transfer of patients, treatment delays, inadequate or inappropriate pre-hospital care, and delay in diagnosis due to equipment malfunction. Another example, in Tehran, a preventable death panel was formed to evaluate all trauma deaths over a 1-year period in a teaching hospital. Prolonged hospital times and deficiencies in resuscitation were found to be largely responsible for the preventable and possibly preventable deaths that were observed. In some low and middle income countries, audits have been used to discern potential low-cost areas for improvement, often when system deficiencies are uncovered by a defining sentinel event. In response to a mass casualty event in 2000, when a hospital in Zimbabwe was overwhelmed by patients injured in a stadium stampede, the hospital's Clinical Audit and Quality Assurance Committee conducted a formal investigation. The report produced by the audit made recommendations for improvements of disaster preparedness that were implemented in multiple contexts, including the pre-hospital setting, all hospital departments, and the Ministry of Health. Although there have been limited experience with trauma QI in most low and middle income countries, there has been more experience in QI in other fields. Many of the examples come from care of medical rather than surgical conditions. There have been some similar progress in fields more directly related to trauma care, including surgery and obstetrics. In Malawi, an audit of antibiotic usage revealed large-scale inappropriate use and led to implementation of treatment guidelines. In Nigeria, the institution of a QI program in a network of primary care health clinics improved the management of diarrhea. In rural India, practitioners' skills in pediatric case management were improved through a QI process that involved provision of standard case management information along with tracking, monitoring, and feedback on performance. In Malaysia, a QI program involving a 2-year audit of 14 hospitals in which all deaths within 7 days of surgery were evaluated by a peer review process. Areas for improvement were identified, and the participating hospitals were informed of the weaknesses detected by the program in order to carry out improvement measures. In Thailand, anesthesiologists established a multi-center registry to detect adverse events related to perioperative anesthesia complications. Some of the best examples of the role of QI programs in low and middle income countries come from the field of obstetric care. A specific type of QI for obstetric care is the maternal death audit. This has proved instrumental in improving obstetric care globally. In Zaire, Nigeria, QI monitoring assisted with the decrease in time interval between admission and treatment from 3.7 to 1.6 hours. In Kigoma, Tanzania, QI-related improvements in the process of care led to a decrease in the case fatality for obstetrical complications from 12.6 to 3.6%. In Nepal, the majority of facility-based maternal deaths were due to correctable factors such as delays in treatment at the facilities, inappropriate treatment, and the lack of blood availability. A model program for implementing maternal care through QI processes was implemented in a district hospital in Senegal, in which senior specialists in OBGYN care reviewed cases daily. This led to a detailed recommendation list for corrective action. These findings and recommendations were then presented regularly to the audit committee. From there, for each maternal death, senior staff interviewed staff concerned and patient's family. From there, the audit committee reviewed standardized information at weekly committee meetings and presented detailed recommendations for corrective action to the audit committee. The next step was that an executive coordination team carried out the recommendations. These actions were carried out by the team including doctors, nurses, and other staff under the supervision of a manager of the district health services. Actions included those taken at the district hospital and throughout the network of primary care clinics. Each subsequent year, the manager of the district health services evaluated how well the recommendations for action had been implemented. The main recommendations focused on improving the 24-hour availability of essential drugs and blood and the availability of basic emergency obstetric care at both hospitals and clinics. Over a 4-year period, the case fatality rate for women delivering at the hospital decreased from 6% to 2.6%, primarily due to the decrease in deaths due to hemorrhage and hypertensive disorders. Improvements in emergency obstetric care are directly relevant to efforts to improve trauma care through QI programs. At healthcare facilities, there is a need for capabilities for resuscitation, including the availability of blood, provision of basic surgical procedures, including both the human resources, including skills and staffing, and the physical resources of equipment and supplies to perform these procedures safely. The Disease Control Priorities Project, or DCPP, review also concluded that in efforts to improve the quality of medical care, policies affecting structural conditions were as important as policies that directly address the provision of care. These findings are directly in line with the most recent approaches to QI that focus on systems issues and not solely on the actions of individual providers. These cost-effectiveness ratios are in range with the most cost-effective interventions studied by the DCPP. Moreover, QI programs themselves can also lead to cost savings. Several of the studies mentioned directly reported cost savings as one of the outcomes, as these are some of the same studies mentioned earlier in the review of benefits and experience of trauma QI in high, middle, and low-income countries. A review of external trauma center verification visits to 179 hospitals in a high-income country showed that the leading factor associated with unsuccessful reviews was the absence or deficiencies of QI programs. The authors of the summary of verification reviews felt that the QI programs were not well understood and that more emphasis on them was needed when developing trauma systems. QI programs are generally regarded as a major foundation of trauma systems in high-income countries. For example, in the United Kingdom, the British Trauma Society mandates that all hospitals caring for major trauma patients should have an audit program to maintain quality standards in trauma care. In high-income countries, there is considerable room for improvement. However, the situation is far more pronounced in low- and middle-income countries. A study carried out as part of the Essential Trauma Care Project looked at the status of trauma care capabilities at 100 healthcare facilities in 4 countries. In addition to evaluating human and physical resources, this study also looked at the status of administrative mechanisms. Notably, formal trauma-related QI programs were completely absent, as were trauma registries with adjustment for severity. The minimal extent of trauma QI programs globally is a major deficiency and a situation that could be improved in a low-cost and sustainable manner. The medical literature shows that trauma QI programs consistently improve the process of care, decrease mortality, and improve other patient outcomes. Therefore, further efforts to promote trauma QI globally are definitely warranted. The previous examples demonstrate the strong support role of trauma QI, the growing body of work presenting the use of trauma QI, the larger body of work on the significant benefit of QI in a variety of other fields, and the significant cost-effectiveness of QI measures in low-income and middle-income countries. All of these considerations reveal the important role that trauma QI can have in improving care and outcome for trauma patients globally, especially in low and middle-income countries.